Yes, very good.
All right, good. So as I said before, I'm Laura Barr, and I'm a family physician. I'm calling in from Holmes County, which is about an hour and a half south and west of Neomed. And I've lived here since 2001, and for 15 years was in a rural private practice, doing pretty broad scope family medicine, and had Amish patients. But more recently, I've been at Springhaven Counseling Center, working primarily with the Amish in an existing mental health facility. So today I'm going to tackle a big topic, and really I decided to cover a lot of ground, but in a general way. Probably any one of my slides you could do a whole talk on, but I thought I'd give you an overview and talk a little bit about who the Amish are and their history and their culture, but also then focus on how they approach their health and finance their health care, and then talk about some medical and mental health issues that are present in the Amish population, and then some challenges that I've observed from providing health care to the Amish over the years. You've probably seen Amish in pop culture. They've made reality TV, they've made movies and books. They tend to be romanticized and idealized, and there's a large tourism industry around kind of the novelty of their culture. They also make the news, some pretty significant events, including school shootings, murders, and hate crimes. They even were targeted in the 2016 presidential election, which is actually kind of funny because they tend not to vote. And when they do vote and participate in civic activities, it's usually for things that would more directly affect them, like property tax issues or local issues. So the Amish were derived from the Anabaptist movement that started during the Protestant Reformation. And the Anabaptists split off from the Protestant Reformation, really arguing for a sharper break from Catholic tradition with more of a focus on separation from church and state. And then they also advocated for adult baptism. They did suffer persecution and so fled Switzerland to other parts of Europe. And then in 1693, a leader named Jacob Ammon had some even stricter and more rigid rules that he advocated. And so from Swiss Anabaptism, there emerged the Amish and the Mennonite. And then both of those groups eventually made their way to the New World to escape the political turmoil and persecution that they were facing in Europe. So the Amish are thought to have come to America around 1730 and settled initially in Pennsylvania. And the author I cited here, Donald Crabel, is a noted researcher in the Amish. He's done a lot of books, even part of a PBS production about them. That if you're ever interested in learning more, if you Google him, you'll find a wealth of information. There's also a Young Center for Anabaptist Studies at Elizabethtown College in Pennsylvania. And they have some really up-to-date demographic information as well as just some general information about the Amish. In June of 2018, there were 330,000 Amish living in North America, and that was up almost 12,000 from the year prior. And their population has been thought to double about every 20 years, and their statistics have shown from 2009 to 2018, the population increased by 39%. They live in 31 states, 4 Canadian provinces, and as of 2015, they've had 2 settlements start in South America, in Bolivia and Argentina. But 63% of them live in Ohio, Pennsylvania, and Indiana, and these are the oldest settlements. Most of their growth is from within. There's rarely people that join from the outside. And the reason they're able to keep growing is that they tend to have large families, and their children, while they do have the choice whether or not to join the church as an adult, a young adult, they usually retain them. And some of that is interesting because it can lead to conflict. They have their time of Rumspringa where they're free to stray a bit, explore the quote unquote world. But the hope and often unvoiced expectation is that they'll join the church. And so sometimes there's a conflict between parents and kids as they're going through that phase. This is just a map from 2010, so it's a little bit outdated, but it does show where the settlements are, and you can see them concentrated in the states I mentioned before. One I wanted to point out was in Florida. They have a settlement down there near Sarasota called Pinecraft, and a lot of Amish winter down there, and they actually have a regular bus service from Indiana and Ohio that runs routes down there. They travel by bus primarily, or hired van or train when they're going long distances. They usually don't fly. And now I'm just going to talk a little bit about some characteristics of the Amish. To the outsiders like us, they all look very similar, but there's a lot of diversity within the Amish. And while they all adhere to very similar, simplistic values and practice a Christian religion, they all draw the line in a lot of different places as to what that means. And their overall goal is to retain their community and their culture, and not advance to the point that people start weighing the individual over the community or depend on things outside of the community. So the leaders in each church district often are the ones that say whether or not they can have a bike, or how they would handle phones. Some have sheds across the road with freezers and electricity, but they're not allowed to have them on their own property. Some are getting into solar. Some lower order groups who are more primitive don't even have indoor plumbing, and use kerosene lanterns in the home. Others, you could walk into their house and they're more modern, and you hardly would know. It's not just a plainer home that any of us could live in. They also have communal styles of clothing. The women wear head coverings, the men grow beards after they get married. And even within that, though, the cut of the dresses and the shape of the head coverings and the color of the dresses can vary. And so when the Amish see each other, they kind of know that's someone from Pennsylvania, or that's someone from this group. They typically attend school through 8th grade, often in one-room schoolhouses that are taught by Amish teachers that don't have any formal education beyond their 8th grade education. They do cover a broad variety of curriculum, and they are literate, but they aren't doing a lot of advanced education because they feel that would detract from them sticking to their culture. So after they finish 8th grade, boys tend to go out and work, often on their farm or in an industry. It's a very gender-specific culture, so the girls will stay home and work with mom and learn the housekeeping tasks. They've traditionally lived on farms, but as the land has become more expensive and the agricultural industry has changed, some have moved more towards becoming artisans, learning a trade, even operating a business out of their home. A lot of beautiful furniture is made in the area. Some are often employed by factories or businesses or in the tourism industry. And I know when I moved here and I was concerned about what their literacy level would be, I was amazed to learn that, despite them only having 8th grade educations formally, many are quite astute in business and do a lot of self-learning, and so are by no means illiterate or uneducated. They're actually bilingual, so they have a leg up on us. They speak their German dialect, Pennsylvania Dutch, in the home, and actually that's their first language, and they don't learn English usually till they go to school. But to hear them talk, you know a little bit of the Dutchy accent, but you don't necessarily hear any problems with them understanding either language, and they often go between the two quite fluidly. You could even make the argument that some are trilingual because their church services are in German in some parts, and they use a German Bible. And so they have definitely been rooted in their traditions, their rituals in the past, and really focusing on their community, sustaining their culture. But they have evolved and changed. They have made changes that allow them to survive in the farming world and the business world, but they do so in a very methodical way so that they can retain their culture and their values. They are very proactive with approaching their health and well-being. They will frequently seek information. They've organized health expos, and they'll have booths set up from all sorts of mainstream medical providers to essential oil providers to anything in between. They often will seek alternative forms of healing. They like high touch, hands-on care. They like providers to listen to them, and they like to use natural remedies, which they see as coming from God and part of His plan for their healing. So they will often turn to those types of remedies before accessing medical care, but they are not against medical care. And some will do it when it's necessary, like an emergency, or they have a critical illness. Others will do it for more routine things, including well child exams and immunization. So that's often a personal or family decision. They will often travel to wellness clinics and chiropractic centers throughout the US and even go to Mexico for surgery and evaluation. They can be lured in by less than reputable providers and really buy into the promise, capitalize on offering them, maybe even misrepresenting what they can offer. And I've seen people go into quite a bit of debt seeking cures before they go to medical care. They are very anecdotal in their approach to choosing treatment. So if it works for someone in their community or in their family, they're very likely to think it's going to work for them. They really value the word of mouth and how things are talked about in the community as kind of their research into knowing if it's going to work for them. They tend not to value preventative care, so it's been hard to engage them in that over the years. I know there have been programs that offer low cost or no cost mammograms and pap smears and well women exams, and those are utilized. But in general, they believe that God is the ultimate healer and they submit to God's will. So this particularly manifests at the end of life when they're less likely to seek aggressive treatments or a lot of life-saving measures. And some of this is economical, but it's mostly part of their religious belief system. As far as their payment for healthcare, they tend to believe that insurance is antithetical to their belief in community accountability. And so a portion of their congregational offerings and tithes is used to help members within their church district. And then for larger expenses, they have fundraisers and community collections. And you would be amazed, they will get the people in a room and make pizzas, make sandwiches, and sell them around the community and can raise hundreds of thousands of dollars through grassroots efforts like that. The Amish church also has a church fund that is a form of self-insurance. And that's what the Amish pay into. And then actually those leaders of that fund can negotiate in pricing with local hospitals and facilities. There's still an expectation that the individual will contribute to the cost, but that does help buffer them when they do face larger expenses. And our local hospitals have developed self-pay packages and discounts that that have really tried to cater to keeping the cost down. And you know, this is a population that will pay. They will pay on time, and they aren't going to have a lot of risk for lawsuits. And then their hospital benefits by not having to deal with the insurer. So it's a win-win in many ways. Some of the things that we might see in practice here, there can be definitely traumas and injuries. And I've got someone at our door here. I need to let my husband know. And then, so we've seen some farming accidents, buggy accidents. You know, we have a lot of hilly, windy roads in the area, and cars versus buggies. I would have expected more accidents than occur, but it's definitely a concern. Some unique things I've seen, you know, with them using less power equipment, they will use traditional wringer washers, and I've seen fingers caught in those. They usually dress with straight pins. Women pin their dresses with straight pins because buttons are considered to be a sign of vanity. And so I've had the cases where women will step on their straight pins because they often don't wear shoes, in their homes or even outside in the summer. And these actually sometimes have to be removed under fluoroscopic guidance. They often will present late to care or to a primary care office to avoid hospital charges. And one incident that I can relay personally is I was finishing up in my practice one day on a Saturday morning, and someone came in right before we were closing, had been doing a roofing at a barn raising and slid down, cut his hand pretty extensively, and convinced me to repair it for him. And I got in there and was flushing him. It turned out he put cayenne pepper in it to stop the bleeding. So what turned into hopefully a quick end to my morning was a 2-hour flushing and repair. But there's times when you're practicing in this area that you accommodate their needs and kind of relax some of your expectations as how care should be provided. I brought this information in because measles has been in the news nationally. We had an outbreak here in Holmes and surrounding counties in 2014. And it started when 2 unvaccinated Amish men traveled to the Philippines for a mission trip and contracted measles. And I will say I never quite understood this. They typically don't evangelize or do mission trips, let alone overseas, but somehow this group did do this and came back with measles, but they weren't ill till they got back. And because we haven't seen measles in the United States, or hadn't for so long, the diagnosis was initially made that it was dengue fever, and so it allowed for the spread of the disease before it was really identified. And so in all, there were 383 cases in 9 counties in Ohio. And it resulted in 12 hospitalizations, but no deaths or severe complications. And it was determined that most transmission occurred in homes and family settings rather than large community gatherings, which was a big concern because they do often gather in large groups for different events. And I think the lesson from this is there was a robust public health response along with a willingness on the part of the community to participate in that response. So that involved isolating cases and quarantining those that were exposed, and then educating the community as well as the healthcare providers. And then they had some mass immunization clinics, which were quite effective at curbing that outbreak. As far as maternity care, the Amish tend to have large families and they rarely use birth control unless it's recommended by a doctor. They often will either come late to prenatal care or use lay midwives and deliver at home. When they do seek prenatal care from a physician, they may be willing to do the normal prenatal labs, but they won't necessarily do the genetic screens and amniocentesis and more invasive things. In order to kind of meet them where they're at, some birthing centers have developed, particularly there's one called Mount Eaton Care Center near me that provide a culturally sensitive, very plain setting for delivery with lots of opportunities for family involvement and very plain, non-hospital seeming setting. But it is medically attended by nurse midwives and doctors who serve that area. They do not have C-section capability, but they do have plans in place for accessing hospital care should that become necessary. And then local hospitals also work to provide sensitive care that's affordable. They have packages and self-pay discounts. And so a lot of practicing in the maternity realm is balancing respect for their wishes and culture and then providing evidence-based care and trying to blend those two parts. One anecdote I could share about this is I had a patient back when I did deliveries that was going to deliver at the care center and called me. The husband called me and said, you know, we tried to get there, but the baby just came too fast and we delivered at home. So can you come out and see the baby so we don't have to go in? And I made the exception to do that and then realized all the things I was giving up by doing that. And I was the one running around the county getting vitamin K and erythromycin ointment to take care of them in their home setting. The other thing sometimes that is a big factor in the Amish is genetic disorders. They are a closed community, and they've all come from a small group of what we call founders in Pennsylvania, and so there's a smaller gene pool with intermarrying of distant cousins that's occurred over generations. And so there's quite a problem with some diseases that have been identified, particularly some metabolic disorders. There's syndromes like dwarfism and cardiomyopathy, hemophilia B. I know our local ER keeps factor 9 on hand to treat when people come in with bleeding complications. There's quite a prevalence of cystic fibrosis. And so several clinics have evolved in areas with a lot of Amish to not only provide testing, but care of the disorders. And there's a lot of research going on. Even there's a group coming to this area from England that's been researching different diseases and identifying them over a many-year period of time, and contributing to the knowledge base on those. And now to mental health. As far as how do the Amish approach their mental health? Well, this article I found was actually published in 2018, and it was out of Geauga County. And they note that little research has been done on not only the epidemiology of mental health, but on the utilization by the Amish of services. But in general, the studies have shown that they do have similar conditions to the non-Amish, although there are some exceptions in some syndromes. Traditionally, mental health issues were handled internally within the community, and counseling and guidance was prescribed by the church leaders. But in recent years, there's been more of a willingness for them to seek care and treatment. And some of that comes from maybe a little bit more education about the biological basis of mental health. I think for a long time they saw it as a moral failure, and now that they see some biological basis, they are willing to seek care, particularly medicine. They're more willing to use medications than counseling, although they are being more open to that, especially if it's secondary, if they're facing something that seems secondary to a life stressor as opposed to something they're attributing to them not living up to some moral expectation. There's also been some fear on the part of non-Amish counselors who could maybe direct people to leave if they don't understand their culture. So this study began in 1998, and some of the agencies in Geauga and Trumbull counties realized that their services weren't being utilized, and so they began meeting with Amish bishops and church leaders to find out why and try to find out ways to collaborate. One example they give in the article is that when the Amish bishops learned that property taxes were funding the services and not the federal government, they were more willing to access those services locally. So over the next 15 years after those focus groups and that education was provided, they actually saw a 320% increase in the utilization of their local mental health care services. So not only were people accessing it and not leaving the county, but they were just accessing mental health care in general. And then this is just some observations I've had related to it. Like I said, there is an increased willingness. Where the Amish will often go is somewhere where they feel like they're getting trusted mental health services. So word of mouth is big. If someone had a good experience at a facility, then someone else in the community is more likely to go there. The other thing I've had to adjust to is how very involved the family and community are in making decisions. So we go through the typical release signing and don't give out information that violates patient confidentiality, but patients will come with a support group that they've set up within their community or with a ministry group or family, and you can have a room full of people invested in helping with the care plan for the patient. So it's great, although it's been an adjustment for me as far as just being so focused on patient autonomy and patient confidentiality. So navigating that cultural part of their culture has been a learning experience for me. They've also developed restoration teams, and these have been created in partnership with local mental health and law enforcement agencies as a way to get help for Amish who are dealing with abuse, particularly sexual abuse. So if there's a allegation in the community of an abuse situation, often the first point of contact for the ministry is the restoration team. But they then will refer people to mental health agencies, and they won't do the reporting, but they know if they're referring someone to a licensed provider, then they will be a mandatory reporter. So it's how they kind of get around being the one to have to do the reporting, because in the past it would get swept under the rug, but now they're willing to get help and not only get counseling and mental health treatment for the victims, but also the perpetrators, as well as having perpetrators who face legal consequences. Substance abuse exists amongst the Amish. Where I'm working, I haven't seen a lot of people seeking treatment for addiction per se, but they're definitely using substances. There's quite a number that smoke as well as drink. And there's a big issue with the Amish youth during their Rumspringa, experimenting with not only alcohol and tobacco, but other drugs as well. There's also a large problem with incest and sexual abuse and other traumas that are common in those seeking mental health treatment. And again, back to what I said at the beginning, where we tend to idealize this culture, there's definitely a darker side to it too. And they're definitely dealing with issues that are very deep-seated and difficult. And I'm just glad to see that they're getting help for those now, as in the past it didn't get addressed. There are some mental health clinics that specifically serve the Amish, and so I'm at Spring Haven, there's Oak Lawn in Indiana, and Phil Haven in Pennsylvania. And so some offer inpatient psychiatric treatment, all offer outpatient, and then I think each of them also offer residential treatment. So we have the Woodside Rest program where I'm at, where men and women will come stay for intensive counseling and psychiatric care. They're not sick enough to need hospitalization, but they come stay in a plain home run by house parents and participate in a curriculum of counseling and group and individual sessions to work on coping skills and get tools to take home and function better in their home setting. It's just a slide with where I work, and we do have an equine program which ties in real nicely to their culture. And our mission is compassionately leading people towards wholeness, which really was an attractive mission statement when I was looking to work at Spring Haven. And so just to end, some challenges and opportunities to providing healthcare with the Amish. They do value shared decision making. Some of that is based on cost. Some of that is they're wanting to be responsible for their healthcare and making those decisions. I've learned to just present options and help guide them. Also cost conscious test ordering and prescribing. They're paying out of pocket, so you don't order every test right off. You do incremental and stepwise care. And one example of this is, typically if you see someone in the office with abdominal pain and you think they may have appendicitis, you don't just automatically send them to the ER. I'll send them for a CBC, and then based on that, decide, do they need a CT scan? Do they need to see a surgeon? And try to circumvent the ER and keep costs down. Reaching them by phone can be difficult. Many do have a phone, but it's not in their home. And so they will have a phone number with a voicemail. Some of the lower order won't even have that, and they will actually have a driver or a neighbor that's a mile down the road as their emergency contact. So it can be really hard to reach them. And I can think back to one time I was covering call for my partner and had someone call me with a critical lab on a baby that was in renal failure. And I ended up driving out to their house and bringing them to the ER because there was no other way to reach them. The transportation is an issue. They're horse and buggy locally, or bike or tractor. But there is a lot of cost for them to hire a driver. And so often when they come to the doctor, that can be a limiting factor, particularly if they have to travel to a specialty care center that's an hour away. There's also language and trust barriers, particularly in lower order communities. I've met with some of the lower order Schwarzentrooper teenagers who actually bring an older family member as functions as an interpreter because they really don't feel comfortable talking to an English person and talking in English, even though they know the language. And then the other thing would be competition with a variety of other approaches to healing, like the wellness centers I mentioned. And just knowing that they're also seeking things other than medical treatments, and making sure we're avoiding interactions or things that are going to be a problem when they're blended together. But in general, I've learned to recognize where there's room for negotiation, where there's gray areas in the treatment planning, and then work with them to build trust and to make decisions together. And I've learned a lot from them about health and healing, and that we don't necessarily have all the answers, and they can be an agent in their own healing. And as long as it's not doing harm, being open to that and working together is very enriching. And that's what I have.